language pathology. I'll repeat. Good afternoon. Thank you so much for this opportunity, and I look forward to having some dialogue with you. As our topic you see on the screen, I'm sharing the screen, is interprofessional approach to dysphagia management, the role of speech language pathologist and dietitian. I am a speech language pathologist. I am the program director at Southern University, and I'm over the graduate students. And so I'm constantly training the graduate students academically and clinically. As you are training as well, you have your academics and you have your clinical component as well, and you're going to run into people like me. So today I wanted to take some time to talk about a couple of things, and let's go through the agenda that I have planned for us today. Is to talk about the role of the SLP and the registered dietitian. I'm just going to be referring to SLP and RD, discuss the purpose of the speech language pathologist, define speech language pathology, discuss collaborative practice, and I'm lumping collaborative practice along with the next item was to define and discuss IPP and IPE, IPC, interprofessional practice, interprofessional education, and interprofessional collaborative practice. And that's really the new thing right now within all disciplines, within that health model, that we learn how to work collaboratively together. So I'll be talking about that. I would also talk about define swallowing and risk factors, list cultural influences as it relates to the diet, describe social aspects that influence the diet, and some holistic approaches as we look for future clinical practice and working in both disciplines. That would be speech language pathology and also registered dietitians. And then the last thing, I have a little Q&A where you can ask questions and things like that, as we move through at the end of the presentations. Okay? All right. So here we go. The next thing is I want to talk about, what is dysphagia? Dysphagia is known as a swallowing disorder. As I put up at the top, I have DYS, means difficult, phasion is to eat, meaning that the patient has problems eating, difficulty eating. And it can occur as a result of various medical conditions. Each year, approximately 1 in 25 adults would experience a swallowing problem within the United States, according to the National Foundation on Swallowing Disorders. And when we look at dysphagia, dysphagia is defined as problems that occurs within the oral cavity, the pharynx, the esophagus, and the gastroesophageal junction. And when we look at persons with aphasia, we're really talking about persons having food is unable to pass through smoothly, and sometimes it gets stuck for patients, which can result in odeophagia, which means that the swallowing is painful. So sometimes patients say, well, I can't swallow. I just feel like I have something stuck in my throat. It's very hard. It's painful. So that's another thing. And when these patients continue to have these complaints, it can lead to GERD, reflux. Sometimes they regurgitate their food and it comes out through the nasal passages. So that's another area. The other thing that we look at when patients have dysphagia issues would be aspiration. And aspiration basically is when food and drink goes down the trachea instead of the esophagus. And that can lead to aspiration pneumonia. And with that happening over time, patients can simply die. Dysphagia can be classified into 3 stages. We have oral, pharyngeal, and esophageal. And for the oral phase, we look at drooling. A lot of times you may be out in the public and you may see a child, or you may see an adult, and you may see some drooling of saliva around the oral musculature. So drooling is a particular issue. If you have your older family members that may be in a SNF facility, or they may be in a nursing home, sometimes we have what we call pocketing of food. And inside the oral musculature, we have food that's stuck on both sides or one side of the mouth. And so they're eating the food, but they're actually not chewing all of the food. And the foods begin to sit down within inside the cavity, or cavity. And so that's a particular area. Sometimes people are eating food and they start spitting the food out of their mouth, or they have difficulty chewing, or they complain of dry mouth. or they have a change in taste sensations, or they try to suck through a straw, but they can't. So that would be that oral phase of dysphagia. The second phase is the pharyngeal phase, and that's a little bit further back in the mouth. And that's where patients will complain that they have food sticking down within their throat. I can talk to a particular person and I can hear their voice quality to know that they have a hoarse voice sound. Some patients also complain of nasal burning that may occur within their nose. Sometimes they have a sniffing sensation while they, trying to eat a meal. As they're eating, they're constantly sniffing while they're eating a meal. Coughing sometimes and choking. So a lot of times I'm at a restaurant and, if you're at a restaurant, you hear people coughing, I just quickly will turn and I have to turn it off because I say, hey, this is not speech pathology. I'm here for enjoyment. So sometimes it gets you where you don't need to be. The next phase is the esophageal phase. And a lot of patients will complain of unpleasant taste in their mouth when they first wake up, in the morning, or they may have an acidic smell breath. Sometimes you have patients who constantly burping all the time, excessive burping, food sticking down in the throat, and they also complain of heartburn. So these are the three key areas when we look at in terms of dysphagia, which is better known as swallowing disorders, that we as speech language pathologists work with. We diagnose, we treat these particular populations. So speech language pathologists have the appropriate training and the competence that are involved in terms of the diagnosis, the maintenance of oral and pharyngeal dysphagia as we move forward and talk about more about this particular population. So when we think about some signs and symptoms of swallowing problems, you see I have here mouth or face weakness, recent weight loss, coughing or choking when eating, trouble breathing when eating, and drooling. The gurgling voice sound after or during eating, the feeling they have stuff stuck down the throat, or it takes them a long time to eat their food. And some patients will avoid certain foods. And those are some key signs and symptoms that family members may need to be more aware of when we get ready to eat our meal. Mom or grandma doesn't want to eat, because they know that what you have prepared to eat, it's a problem for them. And they don't really want to talk about it. They try to hide it for a long time until it gets at a point where, you can no longer hide it. So about 50% of patients with dysphagia, they actually have silent aspiration. And that's the key red flag, I call it, unquote, that we have to really, really be cautious about because, if you don't know they're aspirating, they can actually die. And aspiration occurs at least 43 to 54% of stroke patients. 44% of patients develop pneumonia from aspiration, and almost 4% of them die from these type of problems as it relates to aspiration pneumonia. That's only if it's not diagnosed properly. So if it's diagnosed, then there are some key things that we as speech language pathologists and dietitians can work collaboratively together with the patient to bring about effective change where they're able to manage and live a better lifestyle. So what are some causes of dysphagia? So I'll list a couple of them here, and these are all the type of patients that you'll be working with, you'll be seeing in your clinicals: congenital infections, head trauma, various brain disorders, spinal cord injury, strokes, change in mental status, tracheostomy, head and neck cancers, multiple medical problems, overall weakness. So when you go about obtaining patients' case history, it's important to take into consideration the onset and the actual duration of the problem that we want to know about swallowing. We also want to determine if there are any coughing or airway issues that may be a particular issue, and we need to check to verify that. We also want to know if the problem is continuous, or it's something that's intermittent, or is it something that continues to worsen over time. What is the location? Is it oropharyngeal or is it esophageal? Remember, I talked about 3 stages: oral, pharyngeal, and esophageal. So we have to figure out where is the problem. Where is it occurring, the location? So the other thing you want to know, does the patient have problems with solid foods, or do they have problems with liquids? We want to know. We also want to know if the patient has been having reflux problems, or if while they're eating, they feel like they're going to regurgitate. We have to ask those questions. And we also want to know, is there been some time where the patient has lost weight? And that's also concern for not just speech pathology, but also the dietitian as well. Dehydration and pain, all those things are very critical. And having worked with dietitians in the hospital a lot when I lived in Washington, D.C., you know, a lot of dietitians were concerned about the skin, because if you're not getting the proper water that you need for your body, it can begin to affect the skin. And I know dietitians pay a lot of attention to the skin. They make sure you keep yourself hydrated, and you also worried about weight loss and calorie intake. So we actually just want to get a very good assessment of the overall condition of the patient. And by doing this, this leads to the speech language pathologist coming up with their own oral examination and throat examination they may want to do to try to figure out what's going on with the patient, and may look at other assessments that need to look at swallowing and food and liquids, you know, with the particular patient that may be causing them some problems. Okay, so that's pretty much it in terms of some causes for swallowing problems. Some other causes I have here is gagging. You know, if you try to stick something down the throat, that's what happens, right? So we want to know if the patient feel like they're going to regurgitate when they're eating food. The globus pharyngeus I put there, this is when the patient has a feeling that there's a lump in their throat constantly, all the time. And then xerostomia, you know, has to do with dry mouth, which can lead to dysphagia. And this particular population, the elderly population, they are taking a lot of medications. Some patients are taking 10 to 15 medications or more a day. And there are some medications that can possibly cause xerostomia. So those are some things that we always have to constantly keep in the back burner for us. Okay, so I had a little video, and I'm hoping it's going to play properly, so you can kind of see. One of the things, as we do a physical examination of the patient, the next thing clinically we want to do, if we're working in the hospital or we have a mobile unit where we're going into the SNF facilities, the nursing homes, and we're doing swallowing evaluations, we do what we call a modified barium swallow study with the radiologist, and we look inside to see what is happening when the patient is chewing and when they're swallowing the food. How long does it take them to chew the food, and how long does it take them to swallow? And once they swallow, what do we actually see that's going on? So I'm hoping that the video is going to play properly. Let's see if it's going to come up.
How we become doctors.
State of the art. Let's see. Let me get it to skip. And let me just move it to about right here. And basically, this is what I wanted you to see. As you see, the patient is chewing right around in here. And right around in here, these are the areas that we pay attention to. So you just saw the patient chew the food, and you see this dark color here. And what this tells us as a speech language pathologist here, as the patient is constantly chewing, we see that now this is going deep down in the rib cage now. But I just wanted you to have a quick snapshot let me just go back just for a quick second so you can see what we're looking for. So he's chewing. There we go. All right, right there. So I want to stop it right there. So right around in this area, as you see this dark area here, this is what we call pooling of foods down in the valleculae here in this area. And this is dangerous for us. So those are some things that we may want to look at to determine, you know, what's causing Ms. Jones or whomever the patient is to have those particular complications. And so there are various things that we can do in terms of diet modifications and working along with the dietitian to better help make lifestyle changes for the particular patient. And as you see here on the screen, I did put a couple products up here. This is Thick and Easy, where we begin to take certain liquids and make them thicker so that the patient will be successful to eat and swallow successfully. Another one over here is Stick It, chicken a la king. This is a puree type meal that you can give a patient. And then this is just simple cranberry juice that's been quickened. AquaCare H2O is a familiar company, and all of these companies actually I have experience dealing with, that we deal with. And you know, patients that may say, well, I want to drink cranberry juice. You can still drink cranberry juice and live a functional life, but we have to make some adaptations to those things that you want to be able to consume on a daily basis, where they would have to have, you know, a liquid there for them, right? All right, so let's talk a little bit more about the role of the SLP in various settings. So we are in lots of places, the same places as registered dietitians and hospitals, rehab facilities, long-term care, skilled nursing facilities. We also in outpatient care. We're also in home-based programs where we're doing home health or providing home health services. Our home health-based program, we provide services that way. So as you can see, we are in a lot of different places. Now let's look at two different things here. I kind of wanted you to be able to see side by side the things that in terms of patient care, the speech language pathologist and the dietitian in patient care. So on the left hand represents what we do as speech language pathologists. On the right hand side represents what you will be doing in the future as you move toward, you know, finishing your program. So we assess, speech pathologists, we assess for dysphagia. We do initial treatment plans. We make recommendations for safest route of nutrition. We provide dysphagia therapy and education to patients and family. Working with dysphagia is all about patient education. It's very, very important. Educating the staff, providing training to the staff about various dysphagia topics, collaborating with other disciplines is crucial. So you can get very good outlook in performance with your patient. Palliative care and hospice care is another area that we work in. So in terms of the dietitian, you know your role looking for malnutrition, risk for malnutrition, prevention of malnutrition, nutrition support in terms of tube feedings, focus on education is small compared to the speech language pathologists. Identifying more long-term problems and referring them to the dietitian if needed. Prevention of malnourished, intensive education, long-term management of patient with focus on environmental issues and also social issues. So those are some key things. Also, the SLP make recommendations for discharge to a rehabilitation facility. We also educate staff about dysphagia. We can train them. Also, the dietitian also provides that nutritional support, and they also want to look at prevention of skin breakdown by trying to see us getting enough nutrition as they possibly can for the patient. Those are all critical key things in terms of when we look at both roles of both disciplines. We may be different in terms of our focus, but there are a lot of commonalities in terms of what we do together. Professionals on the team that promote collaborative practice. We have ENT, otolaryngologists, we have gastroenterologists, nurses, registered dietitians, speech language pathologists. What I should have included here would be dentists is another area, OT, PT, most of all the physicians, and also family members. All those play a key factor in terms of working with the patients. Next question is, how do we go about collaborating with each other? As you move into your medical model and working in the hospitals now, we have dysphagia teams, multidisciplinary teams, which meet at set times, frequencies, to discuss, plan, and execute plan of care for dysphagia patients. We also provide education in terms of education in services to our peers, so we can learn more about each other. Documentation is always kept. Tasks are assigned, and the speech language pathologist is usually the case manager over those teams, because as I said at the very beginning, it is speech language pathologists that are actually within our scope of practice. We actually have the ability to diagnose and treat patients with dysphagia problems. The dietitian visits the dysphagia group, and they can also hold in services. with nursing staff as well, along with the speech pathologist, and work collaboratively where we could talk about safe feeding strategies. What would be some key safe feeding strategies for the patient, and also those family members who maybe once the patient is discharged, the patient goes back home, what are some things that we can teach them to do in terms of diet modifications, which we're going to talk about in a couple of minutes, and how do we go about getting their food, blending it up, and all those types of things. So there's a lot of things that we do commonality together that's been so effective. And I have learned so much working with dietitians in terms of nutrition. The other area that I didn't talk about in terms of my background, I have a PhD in speech pathology, but I also have an ND degree, a doctor of naturopathic medicine. And so I look holistically at the patient. And as I know, dietitian, you do nutrition and all those different types of things. I do that too, but I do it from a whole different perspective. So as you see, there are a lot of things that we do together that benefits the patient, which that is the key thing to what we do. Some areas of dysphagia that we look at in terms of management that both are comparable to each other is assessment, diagnosis, intervention, maintenance, and monitor. So those are some key things that we do that's together, even though the speech language pathologist diagnose, but there are some key things that the dietitian can do collaboratively with the speech language pathologist, which makes a whole world of difference for the patient. So the next thing I said was assessment, because I was talking about areas of dysphagia management. So I want to kind of break them down a little bit. Was assessment process. We do a bedside swallow exam, fiber optic exam, the modified Barron swallow, which you just saw that I showed you on the screen when you saw the patient chewing the food, and we look down the throat to see what's happening. Interview, review medical records, charts, and labs. Also, what I provided to you as a handout, I gave you some various assessments that we do as speech language pathologists, so you can have an idea of some of the things that we look at. Not saying you have to memorize it, because I know you're supposed to be having some assignments or whatever, but I wanted to give you some different handouts that will be beneficial to you. You may not think it's worthwhile now, but when you do get out there clinically, you may find it to be very resourceful. And one of the things about interprofessional practice, interprofessional education, is that we learn how to work with each other, not just teaming, but also the types of disciplines that we have and how comparable we are toward each other. Because what's in the middle, in the center there, is always the patient. And we always collaborate doing assessments. We interview patients, dietitians interview patients. We look at medical history. Dietitians also look at that. We look at lab reviews. Dietitians look at white blood count. We look at that too. And you may not think so. You say, why? Well, we want to know about aspiration, and we also want to know about infection. And that may be some similarities that the dietitian would also want to know. We look at the albumin rate. We want to know if there's any malnutrition issues, which is the same thing that the dietitian would want to know. We also want to look at sodium. These are the labs that we're looking at, sodium markers, because why? We're looking at dehydration. We want to know if the patient is dehydrated. Same thing that the dietitian looks at. As I had down here, intake history, weight, review medical records and chart and labs. All those are key factors that not just the dietitian, but also the speech language pathologist want to know. We also look at hemoglobin, the A1C3. That's a marker for us because we want to know about blood sugar control and diabetes. And now there's been lots of research that's been looking at diabetes and neurocognitive problems that patients may have, which is something new that is happening. We also want to know about the bond and the creatine levels too, because that tells us if the patient has any kidney failure, or if they are a high candidate for kidney failure, if not. Or we also want to find out if the kidneys are functioning. So all these are some key things that we all work together, both trying to find out about the patient. So as you can see, there are some commonalities. So I'm hoping as I continue to talk about this, that you're beginning to see that we're not so different. There are some things that we do very similar to each other. So I put here diagnosis. Speech language pathologists can diagnose a swallowing disorder. Dietitians can diagnose malnourishment. Well, we can't diagnose malnourishment, but the dietitian can. And that's very helpful to us because we have to know. SLPs can also identify potential problems in specific related areas such as gastrointestinal, nutrition, where we need a ear, nose, and throat doctor or other known as otolaryngologist. We may need that. The dietitian can determine the weight and the history of the patient. If there's a history of weight loss or if there's a history of weight gain, we want to know. Dietitian identify problems in related areas also, such as what? Gastrointestinal. They also want to know about, they may look at problems for speech and language and dental, and they may also consult the physician. So as you see, there are some things that we do similarly, but with both of us working together, it's a beautiful thing. Both of us work collaboratively together in terms of making a diagnosis. We come together. We share our results with one another. We participate in grand rounds if you're in a hospital setting with other disciplines as we talk about the patient. And most of all, we work together as a team to diagnose those tricky patients because there are always going to be a patient in your caseload that doesn't represent the book at all. You have to rely on what you're seeing in terms of observations, talking, lab work, and sort of that way go through making your diagnosis. So I put my little picture there is sort of like the blind leading the blind, because a lot of times we just don't know. But if we work together, it all balances and works itself out. So I put this chart here. That was an article that was published, Standards of Practice and Standards of Professional Performance for Registered Dietitian, Nutritionist, and Nutrition in Integrative and Functional Medicine in 2019. And basically one of the things that I like so much about this particular one, it gives us a whole idea in terms of the tools that we need to look at medically, professionally, clinically, and also, more importantly, the patient. So as you see here in the center, personalized nutrition care, it lists assessment, diagnosis, intervention, monitoring, and evaluation. So all of these key factors has to do with the body, the earth, the mind, the spirit, and the community. And within this particular circle has a whole lot of other components, what has to do with food, lifestyle, and environment, but those can impact the patient when it comes to dysphagia. It can also impact the patient when it comes to nutrition. The next thing we look at is nutrition, physical signs, and symptoms. What are they? Is the patient suffering from dehydration? Is the patient not getting enough food to eat? They're losing weight. Why are they losing weight? What kinds of symptoms are we seeing in terms of dysphagia? Is the patient able to swallow or not able to swallow? Is the patient having problems swallowing? Is the patient having pain swallowing? All those are some very good key markers. Next would be the biomarkers, metabolic pathways and networks, systems. And then when we look at all of these combined, stress, toxins, pathogens, allergens, and intolerances, all of those are key factors that can impact a patient who has dysphagia complications. So it's important for the dietitian to meet workforce demands by combining the medical nutrition therapy approaches of conventional and integrative and functional medicine that will make a very big impact on the patient care that we provide together. Next, I have here, I call the circle of health, me at the center. And I put the source here. It's an interesting little activity to complete. I've done it with my students and I wanted to share with you. Basically, in the middle, mindful awareness. This is our patient. This represents the clinician and patient education. It's integrative. It looks at two key things: self-care, organized in 8 different components. As you see here, the patient is in the center. We look at physical activity, surroundings, personal development, nutrition, recharge, family, friends and co-workers, spirit and soul, mind and emotions. And all of these play a key factor in terms of what we have to deal with when it comes to our patients in those medical clinical facilities. So if we leave out one, we're missing. So we don't think about the physical, emotional aspect of the patient. then we've lost it. You know, we know our key role is looking nutrition. And then another thing that we look at would be family, friends, and coworkers. So a lot of times we always want to know about that, but sometimes we forget about personal development. We forget about mind and emotions. We forget about the spirit and the soul, and sleep and rest that the patient needs. And then the environment. What role does the environment play for this patient? And what role does the community play for these patients? So me plus self-care plus professional care plus community environment gives us the whole health of that particular patient. So it's very effective. And so I encourage you to try to do the little activity that I have provided as a handout to you, and use it. The next slide I have up here talks about integrative approach to dysphagia. So there are 3 key things that we want to look at will be the disease model, the pillars of health, and the root cause. It's important for us as clinicians to look at the root causes and chemical imbalances that impact our patients. For the dietitian, your role with the speech language pathologist focuses on what? Nutrition, digestive disorders, if some, the immune system, the nerves, the brain, the environment, and the family. All of these are key areas that can affect our patient care. The other I have here down here at the bottom of the tree for root causes will be medications, because there are a lot of medications that can cause a patient to have dysphagia. And so we have to be careful about that. Emotional stress plays a key factor. So we don't deal with our emotions and our stress, we become very ill. Environmental stress, toxins, the foods that we eat. When we talk about diet modifications in a couple of seconds, I'll talk a little bit about that. Infections, pollution, all those are key factors that impact our patients of care. Pillars of health, endocrine, blood sugar management, pH balancing, immune, circulatory, digestive, neurotransmitters. All those are very key factors. The disease model, what we look at will be emotions, pain, inflammation, gastrointestinal, neurological. Those are like some key areas that we will look at, that will work collaboratively with the dietitian. Just kind of keeping those things in mind gave you another graphical way to visualize the role of the speech language pathologist and also the dietitian in terms of patient care. The next here, I said we were going to talk a little bit about interprofessional practice, IPP, interprofessional education, IPE, and interprofessional collaborative practice, IPC. So as you see here, we have the patient in the center. And here we have the dietitian and nutrition. Then right down at the bottom, on the bottom left, we have the speech language pathologist. So all of these people represent this circle, but the key thing is that we have to learn how we work together. We can't work with patients in a silo. We must learn how to work together. We must become knowledgeable about each other, each professions, and respect what we bring into the table when we're making very, very important considerations for the patient. Keep in mind, every decision we make is always based on the patient and the family members. Those are the key people that are involved. So it's a lot that is happening at these clinical medical facilities now. A lot of professionals, a lot of different disciplines. And now what healthcare is saying, let's calm it down a little bit and let's bring it all together, because each of us play a vital role in terms of working with each other. So we can take a statement from another professional and work together. The beauty of it, it meets the need of patient care for that particular patient. So in terms of interprofessional education, defined as, let's define it for a minute. It's an activity that occurs when we're 2 or more professionals. So you saw in that last slide, there were a lot of different professionals that were working together. So let's say we're talking about the speech language pathologist and the dietitian. So when 2 or more come together, they learn about, from each other and each other to be effective in terms of collaborating and also improving the outcomes for individuals and families that we serve. So according to the American Speech Language Hearing Association, that is my professional association for speech language pathology, those are the key factors that we look at when it comes to interprofessional education. Interprofessional practice, break down barriers, professional silos, and enhance collaborative relationships. You know, a lot of times I've worked in skilled nursing facilities, I've worked in nursing homes, I've worked in hospitals, have a private practice. So you're going to find a lot of different things in terms of people wanting to work together and some people not. But we just can't say we don't want to work with a speech pathologist, or we don't want to work with a dietitian, or well, he or she needs to stay in their own discipline, because we're different, but we're really not. All of us have something that we can all relate to each other. And when we look at this IPP, IPE, IPC, we look at multiple providers, as you saw on that last slide, that circle, the patient was in the center, from different professional backgrounds. We provide collaborative, comprehensive healthcare for our patients, educational services. We're working with the patient, and we also working with those families, caregivers, the communities. Why? Because we want to deliver the most highest quality of care across many settings. And so as I talked earlier, that we work in different settings, skilled nursing facilities, home health, hospital, nursing home, private practice, etc. So all of those key things are effective. IPE, IPP, IPC is globally now. It's not something that just occurred in one discipline, but it occurs in all disciplines. And one of the things about our program at Southern University in the Department of Speech Language Pathology and Audiology, we have developed an interprofessional course where we train our students to talk about other different types of professionals. We teach them, we train them, and then we also have clinical simulation that provides them that guidance, that practice before they step out into the clinical realm to begin to get their clinical experience. So we think we're doing a very effective job to better prepare, because, you know, as I look at you, you are the future. And so that medical model of interprofessional practice is out there, is available, and is happening, is occurring on a daily basis. So through application, professionals, we're able to reduce errors if we incorporate this model. We improve quality of care, and most of all, it's safe for our patients. If we work collaboratively together and effectively, then we can reduce most client issues that may occur when we're providing services. We have to continue to recognize the roles of each professional. That's the key thing, okay? We can negotiate and approach and consider concerns raised from one professional to the other. And there will be some differences, but we can all come together for the common good of our patient. Next I have here is talking about some diet modifications and management for the dietitian and the speech language pathologist. I have 4 key areas: lifestyle, SLPs, diet management, eating and diet. And this can vary depending on each patient, but it usually involves 3 key areas. And dietitians, they know this, they do it all the time. Looking at diet texture. The diet texture is also very important for the speech language pathologist, because if the patient has swallowing problems, we need to know what texture of food is safe for our patient to be able to eat and swallow. So those 3 areas will be puree, mechanical, soft, and nectar thick liquids. And all those are key areas that the speech language pathologist is involved in just as much as the dietitian. We make changes to solid food consistency so we can help that patient maintain safe oral intake and address the nutritional needs along with the dietitian collaboratively together. These recommendations can result in clinical recommendations to modify, let's say, a regular foods, which often can result in some anatomical or physiological changes that impact the person in terms of preparation and management. The modification of food texture, where it's chopping or blending the food, can require less chewing, effort, and possibly easier control for the patient, which it reduces the patient's risk of choking while eating, which that's something we don't want to happen. And then the next thing we look at would be food texture. And when we look at food texture, there are some key things that not just the SLP, the speech language pathologist, plays a key role into consideration. Also the dietitian will be dentition. You know, we want to know, does the patient have all their teeth? Do they have dentures? Are they able to function with those dentures in their mouth? Are they able to chew? Is it sitting properly? So poor dentition can in fact impact the patient's probability of being able to eat effectively. Slow eating and self-feeding difficulties, those are things that both the speech language pathologist and the dietitian play a key role together in making very effective decisions. Next, we look at strategies that we may need to reduce in terms of the risk of aspiration. As I said earlier, one of the key things that we don't want our patient to experience would be silent aspiration. And as I said, 4% earlier can actually die from silent aspiration if it's not properly managed. So we want to look at risk of aspiration. We may also want to look at head positions or prosthetic devices that may be effective for the patient. And the speech language pathologist will come up with some exercises that can improve swallow effectiveness. And sometimes those prosthetic devices can be proprio-adaptive cups and straws that would enable the patient to be able to suck something from the straw or eat something from an adaptive type spoon. So lots of things to take into consideration that shows how both of us, the SLP and the dietitian, can work so collaboratively together, which makes a big impact on patient care. Intervention, maintenance, and monitor. So I put two charts here, what the SLP looks at and the dietitian. Well, look at the dietitian recommends a speech and swallow evaluation. So the dietitian will write in the patient's chart, recommend a speech and language consultation, change diet to a different texture, checking in for tolerance of texture. Is the patient eating at least 75% or greater meals? That's what the dietitian is looking for. The dietitian can also make recommendations to the speech pathologist about natural thickeners, tapioca, flour, instant potato flakes, oats, matzo meal, education to the patient and family. Dietitian can also visit the patient to get food preferences. So change in food texture is not so drastic for the patient, and the patient will say, oh, I'm not going to do that. I just can't do that. That's like totally changing my diet. So coming together with the speech pathologist can be very effective. Changing diet texture, as I said, that's something that's very important to the speech pathologist. And having worked with dietitian, one of the things I found so effective was to come up with a plan and begin treatment and problem solve with the dietitian. It works very well to see what we can do differently so that it's safe, it's quality, and what most of all, importantly, it leads to lifestyle change, but the patient is able to maintain it. So those are some key things that we look at. Dietitians also make recommendations for tube feedings, and that's very important as well, because we want to know if the patient is going to be on a tube feeding. We want to know how much food that patient is actually getting on a daily basis. And again, working collaboratively with the dietitian, it gives you 100% support, which gears toward the patient, okay? Shared patient populations that we both serve. I wanted to just put a couple things up there. As you see, cancer patients, Parkinson's disease, stroke patients, spinal cord injury, quadriplegia, Alzheimer's disease and dementia, muscular dystrophy, multiple sclerosis, GERD. We all work with those same populations. Head and neck cancer patients, we want to look at maintaining weight, and protein is very important. And I know the dietitians like to know about anemia. That's something that they really, really like to look for. Parkinson's patients, they like to know about the caloric, how much caloric intake that they're taking on a voluntary basis. We're looking at involuntary movements and tremors that may be occurring with the patients. Also, the dietitian may want to know about malnutrition, if there are any risk, if there are any difficulty feeding, and if it is, what they do. Dietitian can make the referral for a speech and language consultation. And we know that the medications that Parkinson's disease patients take, the levodopa, can cause the patients to become anorexia. So having experience with that with patients, that's something that the dietitians know a lot about, and they can really, really diagnose this very quickly and make some adaptations that will be very effective for the particular patient. Dry mouth, nausea, vomiting, those are key things that not just the dietitian, but also the speech language pathologist are concerned about. Stroke patients, malnourishment is a key factor, and weakness in terms of their extremities. So that way we won't just have the speech language pathologist and the dietitian. We also may want to call in the physical therapist and maybe the occupational therapist as well, as we look at the physical extremities. And where that would play a key factor is we would want to know if the patient able to cut their food, okay? Are they able to feed themselves? Those are some functional things that we want to look at. But the really goal here is to do what we can to prevent malnutrition. So those are some things. For spinal cord injury, we want to know about high protein needs that the patient needs, and risk of skin breakdown. Also, spinal cord injury, quadriplegia patients can have weight gain or weight loss. They can also have difficulty feeding themselves, cutting up foods, and they may need to have their foods chopped or diced as a possibility. And over time, many of these patients will be on they go on tube feeding, like a peg or J tube. So, and those are some things that the dietitian can assist the speech language pathologist about. In terms of Alzheimer's and dementia, having worked a lot with this particular population with dietitians, dehydration and malnutrition, those are the key things. Food safety, oral safety, those are some key things. And having worked a lot with the population, a lot of this population they forget that they've eaten. So, and they will forget that they've eaten, and they forget how to use utensils. So they may have to be fed, but we have to write all those things in there that you would see the patient exhibiting. Also, the patient would need some verbal cues to help them to be able to chew the food and help them to be able to swallow the food as a possibility. And working with the dietitian, we can work together to look at diet texture that may be affected with the patient, the caregiver's roles, if the caregiver is involved, and then most importantly will be end of life issues. And those end of life issues may end up dealing with feeding tubes as a possibility. So in terms of muscular dystrophy, weight management, prevention of malnutrition, as I said earlier, there are 3 stages for swallowing. It's the oral, pharyngeal, and esophageal. So for muscular dystrophy and multiple sclerosis, we're particularly paying attention to the oral phase. We're looking at muscle weakness, drooling, if there's exhibiting factors, difficulty with chewing the food. Those are some things that we look at. And GERD, the last thing I have here in terms of shared population that we both serve and work together with, diet and lifestyle changes to help prevent GERD symptoms. The dietitian will create an individualized nutrition plan with these patients that can work very well with the SLP. All right, so those are some key factors. And then one last thing I want to mention about the GERD would be the SLP can inform the dietitian about the voice quality, that wet gurgly sound, a hoarse sound, a chronic cough that the patient constantly have, to let them know that there's some issues going on about swallowing that need to be looked at. Further complications in terms of heartburn or feeling of choking that may be said to the dietitian with the patient, and then the dietitian can consult with the SLP to see what would be the best way to work collaboratively with the patient. Okay, we wind it down, get into the end now. So we could not end this presentation and not talk about culture, belief, and practice. You all know about culture. It's the values, the norms, traditions of a particular group. And I put here's a Somali Muslim woman refuses to be seen by a male dietitian, which it could possibly happen. And we have to be able to deal with those particular type of issues and figure out how do we go about changing our culture, our attitudes, before we begin to consider tailoring treatment to our patients. We have to have a specific understanding about our patients' cultural background and their needs. We must consider the impact that our own culture might have on assessment and therapy for patients who exhibit swallowing problems. So those are some key factors. And I just put here Somali Muslim woman that, hey, I don't want to be seen by a male dietitian. I want someone else because of my belief patterns. And so we have to do the best we could to possibly see if there's someone on staff that could provide it. But if not, we have to make some adaptations to let the patient know we only have female dietitians here. Is that something that you want to have, that you can work with you, will listen to you, really work hard with you, and I can have your family member involved throughout this whole process, and hopefully that will work. If not, and they're still refusing care, then we may have to refer them out to somewhere else. The other thing I wanted to talk about was cultural biases and assumptions. And, I get a lot of times people say a lot of times, well, I'm African American or I'm Caucasian. I know all about my culture. We do not know everything there is to know about our culture. Our culture changes in terms of environments, our settings, our experiences, our own personal values and beliefs that we were raised to do with our own family. I put here your own personal mealtime structure and how this might differ for other cultures. Time of day, number of meals, utensil preferences. Well, I had experienced a couple times when I was in DC at the National Rehabilitation Hospital. One patient was saying that they eat after 6. And we were trying to work with the dietitian to make the recommendation. We can get the patient to eat earlier, like 4 or 5 o'clock, that would be better. Well, the reason why they ate after 6 really was like between 7 and 7:30, around between 7 and 8, because at 6 o'clock was their prayer time. And they never have any eating at that time. So in terms of, at one time I thought it was, well, we need to look medically, but also we had to back off and think about the culture. We can make the recommendation, but they're not going to do it anyway. Number of meals, utensil preferences. There are some cultures that don't eat with utensils. They eat with their fingers, their hands. And so is that something negative? No. Does it mean they have a disease or disorder? No. We're just talking about a preference and difference in culture. Variance in patient food preferences. This was a very, very key thing I experienced a lot with, because living in Washington, D.C., I was exposed to so many different types of cultures and different cultures and beliefs and patterns and food preferences. Certain populations like certain foods. And so when we start thinking about diet modifications and management, we have to take that in consideration, because what you think may be good for one may be different for another patient. So the patient's understanding or designated cause of the dysphagia is so important. We also have to look at the social impact of food in their culture, going out to eat, religious celebrations, generational expectations. All those are key factors. Cultural differences between the patient and the clinician plays a big factor. So if we don't take these into consideration, then we're not being effective, and we will lose what it is that we're trying to do in terms of providing that high quality care. Recommendations and suggestions for the dietitian and SLP. And my recommendation is to look at what is your food identity, but don't let your food identity impact you in providing very effective services. Utilize a wide cultural lens. As you see, I have YouTube, I have a camera there, I have music playing. So basically what I'm saying is use many different realms that is necessary to meet the needs of your patients. Less talking, more doing, looking at the different types of roles may be effective. Traditional holiday may impact your patient. Some patients may fast. They may be fasting at that time. March is a very typical time where patients like to fast on certain days. If you're Catholic or Baptist, you may say, well, prior to Easter, I'm going to fast. So fasting is a particular problem sometimes, a difference, not really a problem, but a difference. But it can be a problem if we don't take it into consideration. Routines, vegetarian versus vegan requirements. Food can be associated with hospitality and also expression of friendship. We do a lot with our friends. Through COVID-19, we don't really have a lot of times. A lot of times we are our older family members at home alone. And so my mother, she turned 80 today. bless her heart. And but she's able to work and function. She has no issues. But a lot of times I will try to fix my meal around the time that she eats. And we do YouTube or we do FaceTime. You know, it's a social thing. Social, you know, culture shapes our food, it shapes our family members, everything that we do. So food it's a survival thing. Food is what builds our bodies, but it also shapes our culture. So we have to take those kinds of things into consideration. Recommendations continue looking at food prep time and what may be appropriately effective for our patients. Equipment adaptations like blenders, food processors, drinking cups and straws that I mentioned earlier, the plate size, the color. Do as much as we can to create an engagement environment, appropriate utensils, food thickeners, all those things are very important. We should take into consideration. Try to do, when we look at commercial foods versus food that we're going to be preparing at home, try to see how we can make the foods a little bit more appealing. It provides a much healthier option. And even though we know a lot of the foods are not as tasty, and but they are high in sodium, that's another issue that we have to take in consideration, because a lot of our patients that may have dysphagia complications may be taking high blood pressure medication. So we have to take that into consideration. Okay. And lastly, I want to say is that you have to taste a culture to understand it. Diversity is not about how we differ. Diversity is about embracing one another's uniqueness. So if we do that, we're able to be very effective, provide high quality care, and most of all, safe needs of the patients. And more importantly, we meet the needs of the patient. So I have references here, and then now I'm open for some questions and answers that you may have at this time, or comments. So I give it back to you.
Thank you so much, Dr. Nwaefa. Students, do we have any questions?
You got unmute your mic. So can you hear me?
Yeah, I can hear you.
Okay, perfect. Okay.
All right. I want to thank Dr. Nwaefa. That was an outstanding presentation. So students, do you have any questions?
Questions, comments? I know you got some comments. You got to have some comments because you're students. So I hope that I engaged you, made you think about some things that you had not thought about in terms of speech language pathology. Maybe even convince you to come on over to our discipline in speech pathology. You can do dietitian and speech pathology.
Don't take
No, not that. I'm saying, you know, they're majoring in in dietitian. So what I'm saying is they can get a degree in dietitian. Oh, okay, finish that, and then you can also go into speech pathology. You know, it's a beautiful combination to understand, to work with the patient. So now I'll turn it over to you. What comments, questions you have for me?
I don't have a question for you, but I just wanted to say my mom is a speech language pathologist, and so it was really nice to be able to hear a little bit more in-depth information about what she really does on a day-to-day basis. I mean, I know common knowledge and everything, but it was nice to hear a little bit more about it.
Okay, good. Your mom, she tell her hello. I'm glad she chose speech path.
I'll tell her hello, and she's kind of like you too. You said whenever you're in a restaurant or something, you'll hear somebody cough or aspirate, and you feel the need. She does that to me because I aspirate thin liquids, and she gets on to me and she hears me coughing or something. Tuck your chin, she says.
Yes. I have to turn my head sometime. I'm like, I didn't hear that. And I'll say, oh, I wonder, was he choking up? Let me see. What was he eating? You know, so I have to turn it off.
I have a question. Is speech language pathology, is it a doctorate degree, or what exactly do you have your PhD in?
Well, you can get a master's degree in speech pathology and work very well in the profession. And you have to take an examination to get your license. And you also have to do what we call a clinical fellowship year in a hospital or a school or nursing home, SNF facility, various settings. And you can also obtain a PhD in speech language pathology.
Okay, thank you.
Okay.
Any other questions?
Can you actually talk more about your degree in the holistic medicine? Okay. I'm just a little more interested in that.
Okay. Well, one of the things I wanted to know, I was always learned a lot from my parents about herbs. And then my husband, it happens to be international and traveling. I've been all over the world, Africa, Europe, everywhere. And I had a strong interest in learning more about herbs and nutrition. And what I found is that a lot of places outside of the United States do a lot of different things that are safe and for food and healthy. And so I began to reach more about that. And then I decided to put myself in school. So I went to school at Trinity College of Natural Medicine and I learned a lot. And then I went to lots of different trainings and I had to do a clinical fellowship and then I had to do a license, exam, and all that stuff. That's what you got to do in every discipline just about these days. And so basically I combine herbs and nutrition together. I look at the patient holistically because emotions and stress play a key factor of health. Herbs can be used for just about everything that we need for our bodies to heal it. So I've worked with a lot of patients in terms of cancer patients, oncology, and I found herbs and nutrition would be very effective. I did part of a fellowship in Mexico with some world-renowned doctors that treat patients. I call it outside the box because we talk about Western medicine versus holistic is totally different. So I'm a firm believer in terms of herbs and nutrition. I think it was put on this earth for us to have the medicine and things that we need because food is our medicine. And so I live by that example every day. So everything we put in our mouth, if you don't watch it, if it's not healthy, it causes down the road diseases and disorders. So that's sort of answer your question. You wanted to know a little bit more about my
No,
background.
that's good. Thank you.
Okay. All right.
Are there any other questions?
I have another one, kind
Okay,
of
good.
piggybacking off of the holistic thing. So I know that I'm a pre-med major, so I know that DO, like osteopathic, is more holistic and it's starting to become like more prevalent. Do you ever find like a difference when working with a DO rather than an MD from like a holistic approach?
Yeah, I think the deal is a little bit is much better. But what I'm finding is when I go to get my CEUs a lot every year, I'm seeing a lot of medical doctors, MDs there. Um, Chiropractors there as well, nutritionists want to learn more about that, and RNs and nurse practitioners are leaning more toward that. Now, Western medicine does not want us to do it, period, honestly. And so we have to work under the radar to be effective in terms of providing services for people who want to do that holistic approach in terms of herbs and nutrition. And so I deal with herbs from all over the world with my patients. Then nothing you can find from Walmart or Whole Foods. And so it's all based on functional integrative medicine. And I've seen it work with children and adults so effectively. And so, as I say, what you eat is what you put in your mouth. Either it's healthy or it's not healthy. And it's about thinking and planning and coordinating about, what types of food should I eat? Like we like sodas. I always tell patients what's an alternative to a soda. You can drink a Perrier water or, a sparkling water, and you don't have to, you still get that carbonated that you want, that backup that you need, but it's not the soda. So we just have to begin to read the labels, know what they're putting in our foods because manufacturers are taking away all the nutrients that we put in our foods and it's causing a lot of problems. So we may be depressed and it may be that you don't have the proper nutrients. You may need more amino acids and things. So, and
Thank
I'm,
you.
I have a
pollution,
question.
pollution.
I have a question. So, have you been able to use the holistic approach in the nursing home setting?
A little bit, but it's a little bit different. But in terms of working with the diet modifications, in terms of some of these manufacturers that do the thickeners and the different puree types of foods, a lot of it, as I said, is very high in sodium. And so they have not taken that into consideration. I have not yet. I haven't found a manufacturer that produces pureed foods that is low in sodium. Or there may be some that's very high in sugar and carbohydrates. And we have, as you know, working with the elderly populations, diabetes and high blood pressure, those are two key factors. And most of them are on medications. But what I've been able to do is to educate the families. And I will encourage them to make sure they put their mom or their dad or grandparents or aunt on a probiotic because it will help with the bacteria.
Okay, a healthy gut. Okay.
Yes. Mm-hmm.
Are there any other questions?
Is there any sort of like significant research or any recent breakthroughs in the field that have taken place over the last couple of years?
When you say effective research, are you talking about holistic medicine? Are you talking about what?
More of like speech language pathology.
There's lots of research about speech language. Are you talking about working with various patients or?
Yeah.
Yeah, we've had, there's lots of research about what we do in speech language pathology, working with children and adults, and just about every discipline. So as you saw on the screen, I listed all of the different types of populations that are comparable to a dietitian. So all of those patients those populations that I listed, there's research in speech and language pathology about each one of them.
Thank you.
Mm-hmm. What's lacking? I can tell you that what's lacking in all of our professions is looking at culture and linguistic diversity. And we have to be about that change about culture and linguistic diversity because of our demographics are changing. So you're going to see them out in, the nursing facilities, SNF facilities, so we have to better prepare our students so that we're ready. And we're going to see an influx of working with patients from different countries. Bilingual education, that's also going to be a big factor. And I would say maybe 5 years from now, maybe sooner than that, we're going to be looking at incorporating a foreign language course within your particular major. Now, you may get it at the undergraduate level, but I'm talking specifically geared toward that particular discipline. Like we have a study abroad program where we have our students to go, like last year we went to Belize. So we bring our students in a different country so they can have an experience to provide clinical services in a different population. Did I answer your question?
Yes, ma'am. Yes, ma'am.
Okay.
Just to piggyback off of what Dr. Nwaifa said, when I lived in Arizona, when I worked at the WIC office, I did not speak Spanish, but I had a translator standing behind me speaking as when I was speaking. So diversity is very important in understanding other cultures, because I was trying to provide like the patients with a breast pump and they were very offended, very, very offended about the breast pump. And it's because they didn't think it was natural.
Yes.
To actually put the baby on the breast. And we were trying to give them these breast pumps. And if you know the cost of a breast pump is $300-400, right? And we're giving this free to them, and we thought we were doing a good thing, but they were actually offended.
Yeah.
So you have to know, cultural differences.
Yeah, it's very important.
Any other questions?
I'm interested in how you work with like patients with like Alzheimer's disease, because like my grandma died from that, and like she thought that some of my cousins were actually the devil. So like how do you like communicate with that group of people?
Well, in terms of Alzheimer's disease for speech language pathologists, we look at it from a neurodegenerative perspective. So we have a course that talks about cognitive issues in terms of memory. We focus mainly on 2 areas of the brain, would be the amygdala and the hippocampus, which has to do with memory. And so when you look at the diagnosis of someone with Alzheimer's, you really don't know that they have it unless you do the autopsy on the brain. So basically what we're going by is some lab work, we're doing by characteristics, behaviors they're exhibiting, and those types of things. But there have been some research to show that there are some genetic markers that you can get some genetic tests to see if you may be a particular person down the road that may have Alzheimer's. But then in terms of the cause, there's lots of controversial issues with the government in terms of what causes Alzheimer's. My take on it, this is only my personal take on it, I think it's an environmental toxin, because there are lots of things with our environment that is causing us and making us very sick. I took on Energy, Energy, our electrical company. They have the meters, the meters on your house, right? So I'm just getting a little personal with you. The meters on them, they can cause a lot of different problems in terms of heart problems and so on. And there were some parents in Lafayette, Louisiana, that decided to take on Energy, and they had to remove them So there are two types of meters, the analog and the digital. So Energy decided that they were going to change from analog to digital meters because it would prevent their workers from going to house to do the meters. All they had to do was sit outside their house in the car and they could do the meters, or they don't always have to be around within the neighborhood. So those meters, which they call smart meters, have more radiation than a cell tower. And so they're supposed to tell you as the person that you would want that in your house. They're supposed to knock on your door and say, hey, Miss So-and-so, or Mr. So-and-so, I'm coming and I'm going to give you this meter. This is something you want. Well, they didn't do that at my house. They just installed it. And so I wrote a letter to them and I laid out all the research, and 2 days later, they changed my meter and put it back to analog meter. And so, I have, so in terms of Alzheimer's disease, I think a lot of it has to do with the environmental toxins. But I think if you keep your gut healthy and you take some probiotics, we need them every day. We need enzymes. If you take those things, eat a very healthy diet, possibly, maybe, you may be able to do some things about it. But there's still so much unknown about Alzheimer's. And last year, we tried to write a grant with NIH to look at the impact of Alzheimer's disease within the southeastern United States, because NIH, they do not have a research center that covers the southeastern area. So we're still working on doing that and collaborating with some professionals all across the country to try to do this big research project. So I'm hoping by next year, we may be able to get the funding to be able to have a better understanding about the caregivers, the cultural and linguistic diversity, and why is it you'll find in some states there are more people with Alzheimer's than it is in others. And so we don't really know the cause of that. But I think looking at the research they found with the protein and the genetic markers, the lab testing would probably be very helpful for you to, moving forward as you get a little bit older. But not to say you're going to have it, because every disease doesn't mean that your mom had it, means that you're going to get it. That's my take on it from a holistic perspective.
Are there any other questions? This is your time to ask questions to another professional. Well, Dr. Nwaifa, I really appreciate you taking this time out to speak with the students. I personally learned a lot. I've worked with speech language pathologists, and I appreciate all that you all do. Just to give you guys a personal touch, my son has to see a speech language pathologist. And if you would have heard my son's speech 2 years ago, and you hear him today, how articulate he is and how he pronunciates things, I really appreciate the work that SLPs are doing throughout the schools and throughout the hospital. So Dr. Nwaifa, I really appreciate you coming and speak with the students and appreciate you being in the field. You guys give her a round of applause. I know she can't hear you, but she can see you.
Thank you.
We really appreciate it. So if you want to sign out, Dr. Nwaifa, you can. Students, I'm going to stop recording, but I need to make a few announcements.
Okay, thank you.
Thank you,
Bye.
Dr. Nwaifa.